Hello all. So welcome to INI-CET May 2024 recall for the questions of pharmacology. So this time the questions were medium to hard and they were more of conceptual, plus they were more factual also. So let's talk about the first question. UTI, that is urinary tract infection causing drug among the following is. The answer for this question is gliflozin. Any drug ending with the word gliflozin is a SGLT2 inhibitor. Now SGLT stands for sodium glucose transporter inhibitor. So these drugs, they inhibit SGLT transporter in PCT of nephron, which causes sodium and glucose excretion in urine. Now beta, if there is glucose excretion in urine, which you call it as glycosuria, can we say glucose will promote the growth of microorganism in urinary tract? Hence, these drugs have a side effect of urinary tract infection. So we can remember all the side effects of SGLT2 inhibitor with the help of a mnemonic U-fold, which we have discussed in regular lecture. U for urinary tract infection. Also, it can lead to infection in genital area, which leads to Fournier's gangrene. Now, these drugs also increase the risk of osteoporosis. The reason is, apart from sodium excretion, these drugs also promote calcium excretion, which leads to bone destruction because calcium is going in urine. These drugs have been associated with limb amputation. They reduce the blood supply to lower limbs and necrosis of lower limb happens. And lastly, these drugs, they increase the risk of diabetic ketoacidosis. So remember a mnemonic U-fold, it's a very repetitively asked question. Next question is a diabetic with HbA1c of 7.8 with hypertension and the blood pressure is 60 by 100, 160 by 100, and the patient is having low ejection fraction, that means the patient is having heart failure also, hypertension and CKD, that is kidney disease also. So which drug is preferred in this patient to treat diabetes? Again, the answer for this question is empagliflozin, which is SGLT2 inhibitor. Now we have already discussed that SGLT2 inhibitor causes sodium and glucose excretion. Now, because they promote glucose excretion, blood glucose level will fall, hence they have anti-diabetic action. They lead to fall in blood glucose level. Now, because they cause sodium excretion in urine, these drugs have diuretic action. Now, because of this diuretic action, blood sodium level reduces. Sodium causes increase in blood pressure. There is loss of sodium in urine. Because of this reason, they have anti-hypertensive effect. So the patient was having hypertension. Second point, because of anti-hypertensive effect, these drugs, they reduce blood supply to the heart. Hence, these drugs, they reduce preload on the heart. And because they reduce preload in the heart, they have cardioprotective action in cases of heart failure patients, especially chronic heart failure patients. Now, because they are reducing blood pressure, can we say they will slightly reduce GFR also, glomerular filtration rate? Now, excessive hyperfiltration leads to nephron damage. Because of this reason, they reduce hyperfiltration injury in cases of CKD, chronic kidney disease. That is why these drugs also have nephroprotective effect in CKD. So can we say all these effects, they satisfy the diseases a patient is having in our question? Now, the proof of this thing has been given in our pharmacology book, Goodman and Gilman. So, gliflozin-like drug like empagliflozin, canagliflozin, it is clearly mentioned they decrease specified cardiovascular event and they reduce the risk of heart failure. So, you can see heart failure is written. So they are good for heart failure. And also Goodman and Gilman mentions that these drugs decrease the risk of progression of renal disease as well. The reason we have already discussed. Now the next question is, which of the following drug is not useful in type 2 diabetes mellitus with renal progression? Again, the patient is asking CKD. Now remember, can we say this CKD is because of diabetic nephropathy? So we will label this CKD due to diabetes as diabetic nephropathy. Now to protect kidney in diabetes, the drugs which reduce the damage of kidney, if the CKD has happened, there are three drugs, SAF. The first drug is SGLT2 inhibitors, we have just discussed. And all SGLT2 inhibitors, they end with the word gliflozin. So canagliflozin, dapagliflozin. ACE inhibitors, which ends with the word pril, are the drug of choice as the first drug to be started in cases of diabetic nephropathy. And lastly, a new drug just 1 year back got approved specifically for diabetic nephropathy is finerenone. Finerenone is a brother of spironolactone and it blocks aldosterone receptors. So it is an aldosterone blocker. Remember, aldosterone is a hormone which causes liver damage, heart damage, kidney damage. Excessive aldosterone is bad for organ. So let's block aldosterone receptors with finerenone. Now, the option which was to be ruled out is hydrochlorothiazide. So this is a thiazide diuretic. Thiazide diuretics do not reduce the risk of kidney damage in diabetes. Rather, thiazide diuretic, they increases blood glucose level. Because they increase blood glucose level, they rather increase the risk of diabetes mellitus. They are bad for diabetes. Hence, the answer is hydrochlorothiazide should not be used. Now, the next question is, which of the following drug causes unexplained diarrhea in diabetic people? Beta, we have already discussed very well the drug of choice for diabetes, especially type 2 diabetes, is metformin. And the most common side effect of metformin is GIT upset. And in GIT upset, it causes nausea, vomiting, and prolonged episodes of diarrhea, which is the most common side effect of metformin. Now, why metformin causes unexplained diarrhea? Let's see what our books mention. So we can see the most common, this is Goodman and Gilman 14th edition, most common side effect, that is 10 to 25% of the people who are on metformin, they suffer GI abnormalities like nausea, indigestion, abdominal cramps, and diarrhea. Diarrhea is a specific side effect of metformin. Now, why it causes diarrhea? The reason it is mentioned, metformin has a direct effect on GI function because it interferes with the absorption of glucose and bile salts. So if these bile salts are not getting absorbed, they are excreted in feces, which leads to malabsorption. Malabsorption leads to diarrhea. Now the next question is true about teriparatide. Now first, what is this drug teriparatide? You can see paratide word is coming, para word is coming. So teriparatide is a recombinant form of parathyroid hormone, and this is given in the treatment of osteoporosis. Now let's see what is the option true about teriparatide. Teriparatide causes osteonecrosis of mandible, false. It causes subtrochanteric femur fracture, false. Now A and C, these are the side effects of rather a different class of drug, which is the drug of choice for osteoporosis. They are the drug of side effect of a drug, bisphosphonates. Now, bisphosphonates are the drugs which ends with the word dronate, like alendronate, residronate, pamidronate, zolendronate, you have heard. Now, let's write first the side effects of bisphosphonate. We will write with the help of a mnemonic ROSE. Okay, so bisphosphonate, they causes renal damage. They should not be given in the patient of renal disease. They produce osteonecrosis, damage of the bone of mandible or jaw. They cause subtrochanteric femur fracture. Subtrochanteric femur fracture. Now, subtrochanteric femur fracture is seen when we use bisphosphonate for more than 10 years. If we use them for more than 10 years, they can lead to femur fracture, and they are the enemy of esophagus. They cause inflammation of esophagus, which is known as esophagitis or reflux esophagitis. Now, what about teriparatide? So, side effects of teriparatide is, we can remember with the help of a mnemonic ROAD. R-O-A-D, ROAD. Now, teriparatide causes renal stones, not renal damage. Renal damage is by bisphosphonate. Renal stones is by teriparatide. Teriparatide causes one cancer known as osteosarcoma. Because of the risk of osteosarcoma, it is contraindicated in a disease known as Paget's disease. So, which is the drug of choice for Paget's disease? Remember, the drug of choice for the treatment of Paget's disease is bisphosphonate. And because of the risk of osteosarcoma, teriparatide is contraindicated beyond 2 years of use. We don't give teriparatide beyond 2 years, and we don't give bisphosphonate beyond 10 years because of subtrochanteric femur fracture. Teriparatide increases ALP levels in bone, alkaline phosphatase, and it increases the risk of distal radial fractures. Now, teriparatide, how do we give? So, before coming, how do we give? So, it causes osteosarcoma in Paget's disease. So true, this is the B is the correct answer. Now, teriparatide, it is ending with the word tide. Tide means peptide. Peptides cannot be given orally because pepsin trypsin enzyme will degrade. That is why teriparatide is given by injection. Now, remember a concept of physiology and pharmacology, that when parathyroid hormone, it is given as a pulsatile or intermittent injection. Intermittent injection of parathyroid hormone stimulates osteoblast, OB in bone. Because of this reason, it causes bone formation, anabolic effect. That is why in osteoporosis, we give intermittent injections of teriparatide. But when this same parathyroid hormone, it is given by continuous injection, it rather stimulates osteoclast. Now remember, if there is osteoclastic stimulation, osteoclast will destroy bone. It will lead to bone destruction, which is also known as bone resorption. So can we say it will destroy bone and it will increase the risk of osteoporosis? Yes. So that is why we never give continuous injections of teriparatide. We always give intermittent injection of teriparatide for the treatment of osteoporosis. Now the next question is, a pregnant mother delivered a baby, but the neonate died after a week. But don't you think the female is ready for breastfeeding, but the neonate has died? Now, to prevent this breastfeeding or breast engorgement, which drug to be given? The answer for this question is cabergoline. Now, what is cabergoline? Or a similar drug, bromocriptine, can also be given. These two drugs can be given. Cabergoline and bromocriptine, they stimulate dopamine D2 receptor. Now they stimulate dopamine D2 receptor in pituitary. Now remember, if we stimulate this dopamine D2 receptor on pituitary, dopamine inhibits release of prolactin. So hence it inhibits prolactin release. So dopamine is a inhibitory neurotransmitter which inhibits prolactin release. We all know prolactin is responsible for milk production. Hence it reduces milk production. And if there is decrease in milk production, the breast size will reduce. Can we say it will reduce breast engorgement or swelling of breast? So the answer is cabergoline or bromocriptine. Now the next question is, which of the following anticoagulant drugs require coagulation monitoring like PT or APTT monitoring? The answer for this question is lepiridine. So let me explain you what about all other drugs, enoxaparin, fondaparinux and dabigatran, they do not require any monitoring. So let's make a summary that which anticoagulant drug requires monitoring, which does not require monitoring. So let's classify anticoagulant drugs into two types. First is oral anticoagulant drugs. Second, we have injectable or parenteral anticoagulant drugs. Now, oral anticoagulant drugs, they are further divided into three types, depending upon which clotting factor they are inhibiting. The first class we have is vitamin K antagonist. And in this class, we have a very famous drug, warfarin. We all know that warfarin inhibits vitamin K, and vitamin K is responsible for synthesis of 4 clotting factor. Hence, it reduces the production of 2, 7, 9 and 10 4 clotting factor. The next class of drug we have is the drug which only inhibit factor 10. So factor 10A inhibitor, these drugs, they have XA word in them because XA is factor 10 activated form like apixaban, rivaroxaban. So these drugs, they inhibit factor 10 only. Lastly, we have the drug which inhibit factor 2 or thrombin, direct thrombin inhibitor. And the only drug we have among oral is dabigatran. D for dabi, D for direct, TR for thrombin, AN for antagonist. It inhibits factor 2 only. And among parenteral anticoagulant drugs, we have again direct thrombin inhibitor. And these direct thrombin inhibitors parenteral are heriudin, lepiridine and ergatroban. A different name, ergatroban. And lastly we have is indirect thrombin inhibitors which indirectly inhibit thrombin by activating antithrombin. They are known as heparins. Now these heparins, they are further divided into three types. That is high molecular weight heparin, low molecular weight heparin and ultra low molecular weight heparin. Now low molecular weight heparins, they end with the word parin like enoxaparin, which was given in the option, dalteparin. While ultra low molecular weight heparin, they end with the word parinux like fondaparinux given in the option. Now let's see which anticoagulant drug require monitoring. First about oral. Remember in oral, warfarin requires monitoring because it is inhibiting multiple clotting factor. Hence it will be a dangerous drug which can increase the risk of bleeding. So warfarin requires PT monitoring, which we call it as PT with INR monitoring. While factor 10A inhibitor and dabigatran, they do not require monitoring because they are very safe drug. They only inhibit one clotting factor. Now among parenteral anticoagulant drugs, any drug which is an IV drug requires monitoring. So lepiridine, heriudin, they are IV drugs. High molecular weight heparin is an IV drug. while rest all other drugs like low molecular weight heparin, ultra low molecular weight heparin, they are subcutaneous injection. They do not require monitoring. They are safe to be used. And IV anticoagulant drugs require APTT monitoring. Now, in our question, we were having an option of dabigatran, no monitoring, fondaparinux, no monitoring, enoxaparin, no monitoring, but lepiridine was asked, which requires APTT monitoring. Now, the next question is, which of the following is HER2 inhibitor, not HER1 inhibitor? Now, HER, it means human epidermal growth factor receptor. Now, mutation in this growth factor receptor can lead to excessive growth and cancer. Now, this HER receptor is of two types. One is HER1 and HER2. Now, HER1 mutation, it leads to non-small cell lung cancer, while HER2 mutation leads to breast cancer. That is why we have developed the drug which inhibit this receptor given for the treatment of cancers. So the drug which is HER1 inhibitor, a very famous drug is cetuximab. And two new drugs are panitumumab and necitumumab. So that is option A, option C and option D. They are HER1 inhibitor. And in breast cancer, the HER2 inhibitor are a very famous drug, that is trastuzumab and a new drug pertuzumab, which we have already discussed in rapid revision and regular lectures also. So the answer for this question is pertuzumab. Okay. So they are given in breast cancer. Now the next question is, which of the following anti-leprosy drugs causes skin pigmentation? The answer for this question is clofazimine. What we discussed in lectures was that if we talk about the history of clofazimine history, before it was developed as an anti-leprosy drug, it was used as a coloring dye. It was used as a color dye in textile industry to color textiles. Now, when this drug is taken for the treatment of leprosy, it causes coloring abnormality in whole body. So, the side effect of clofazimine is color abnormality. So, which color abnormality? It causes hyperpigmentation of skin. Now, why this side effect is very important? Because in leprosy, patient itself has coloring abnormality in skin. And when patient takes clofazimine, again, another type of skin discoloration develops. And doctor and patient confuses that whether the leprosy is increasing or not. So that is why we must keep this side effect in mind, that clofazimine can also cause skin coloring abnormality. Do not confuse with the lesions of leprosy. So that is why this question is specifically asked. Now the next question is, match the following diuretics. Now let's see first all the diuretics where they act. So if I will draw a nephron, this is PCT, proximal convoluted tubule. Then we have descending limb of Henle, loop of Henle. Then we have ascending limb of Henle. Ascending limb of Henle is known as thick ascending limb, and it merges with DCT, distal convoluted tubule, and finally nephron drains into collecting duct. Now remember one point, that DCT and thick ascending limb, these two portions of nephron, they are combined. When they are combined together, they are known as distal tubule. Okay, and this hairpin loop is known as loop of Henle. Now the first class of diuretic is carbonic anhydrase inhibitor. Carbonic anhydrase inhibitors, they act at a level of carbonic anhydrase inhibitor, they act at a level of PCT of nephron, and they inhibit absorption of sodium. Sodium will be lost out in urine, hence they have diuretic action. So classical example is acetazolamide. Then we have osmotic diuretic. Osmotic diuretics, they act at a level of loop of Henle. And a classical example is mannitol. Now, in thick ascending limb, loop diuretics they act. They inhibit certain specific transporter known as sodium potassium 2 chloride transporter, and the classical example is furosemide. While in the upper portion of DCT, thiazide diuretics they act, and they inhibit another transporter known as sodium chloride symporter in DCT of nephron. While in collecting duct of nephron, the last diuretic, that is potassium sparing diuretics, they act. And the classical example is spironolactone. Spironolactone. So these are the various areas where diuretics they act. So let's see, osmotic diuretic, loop of Henle, true. Thiazides and loop diuretic like furosemide, DCT. Okay, so thiazides they act on DCT, while loop diuretics specifically, if we write, they act on thick ascending limb. Acetazolamide, PCT, and potassium sparing diuretic, collecting tubule. So if a question which we can recall properly, which is an incorrect statement will be loop diuretic do not act on DCT. They rather act on thick ascending limb, while thiazide diuretics they act on DCT. But some students were telling me instead of DCT, distal tubule was written. If distal tubule is written, then the answer is yes, both thiazide and loop diuretic they act on distal tubule, because distal tubule is a part which is a combination of thick ascending limb and DCT. So next question is, which of the following is not treated using cannabinoid? Now beta, recently a drug which is derived from cannabinoid has been developed known as cannabidiol, and this cannabidiol, it has been approved in the treatment of seizures or epilepsy. Now it has been approved in 3 rare epilepsies causes. The first is, it has been approved for infantile spasm, which is associated with a genetic condition known as tuberous sclerosis. It has been approved for Dravet syndrome, which is also known as myoclonic epilepsy of infancy. And lastly, it has been approved for Lennox-Gastaut syndrome. Lennox-Gastaut syndrome. So 3 areas where this cannabinoid have been approved. So where it is not given in Rett syndrome. Rett syndrome is not epilepsy. It is a neurodegenerative disease, and the only drug approved for Rett syndrome, which was asked previous year exam also, the only drug approved for Rett syndrome is trofinetide. No other drug has been approved for Rett syndrome. Now the next question is, Sugama Dex is used to rapidly reverse the effect of which skeletal muscle relaxant? So skeletal muscle relaxants are used during surgery so that patient does not move, and after surgery we have to reverse the effect of skeletal muscle relaxant. Sugama Dex has been recently approved for the reversal of effect of 2 skeletal muscle relaxant. The first is rocuronium and second is vicuronium. Only for these 2 agents we give Sugama Dex. Sugama Dex directly binds to these 2 skeletal muscle relaxant and reduce or block the effect of these 2 skeletal muscle relaxant. So the answer is rocuronium. Next question is, what is the mechanism of action of tetanus or tetanospasmin toxin? Now suppose beta, this is a neuron and this is a muscle. Now understand one basic concept. if this neuron releases acetylcholine. Acetylcholine is an excitatory neurotransmitter. It causes contraction of muscle. And if you can recall properly certain inhibitory neurotransmitter, yes, the inhibitory neurotransmitter is GABA and glycine. These are inhibitory neurotransmitter and they causes relaxation of muscles. Now there is a bacteria known as Clostridium bacteria, like Clostridium botulinum, Clostridium tetani. Now remember that there is tetanus toxin. Tetanus toxin inhibit the release of GABA and glycine, while botulinum toxin inhibits the release of acetylcholine. Now, can we say the effect will become opposite? Botulinum toxin inhibit the release of acetylcholine, muscles will not contract, hence botulinum toxin will lead to relaxation of muscles. While tetanus toxin will lead to spasm of muscles or contraction of muscles, because they inhibit the release of inhibitory neurons. That is why it is known as tetanospasmin. Hence, the answer for our question is A. They inhibit the release of GABA and glycine. Now, the next question is, which of the following, it's a new question which was asked this year in INI-CET exam. Now, this voriconazole is a very special drug. We have to remember all the details. It is commonly used in hospitals to treat or prevent fungal infection. So, what is false about voriconazole? Now, voriconazole, it should be combined with pyrazinamide. Now, this is a false statement. So, answer for this question is A. Now, voriconazole and pyrazinamide, they both are hepatotoxic agents. We know that the most hepatotoxic TB drug is pyrazinamide. Azoles like voricanazoles are hepatotoxic. So if they are combined together, the risk of hepatotoxicity gets increased by more than 70%. That is why we avoid combining voriconazole with pyrazinamide. Now voriconazole should be taken empty stomach, true, because fatty meals reduce absorption of voriconazole. Now, loading dose should be given. The answer is true. Loading dose or initial higher dose is given with voriconazole, especially in the patient of liver disease. And TDM or therapeutic drug monitoring should be done. Again, the answer is true. The reason is voriconazole, it is metabolized by or degraded by an enzyme known as CYP2C19 enzyme. Now, this enzyme shows polymorphism. Polymorphism means some people have higher amount of this enzyme, some people have lower amount of this enzyme, but in the patient with varying amount of this enzyme, voriconazole will be degraded by a different rate. So if it is degraded by different rate, the blood level among individuals can vary. That is why in each individual, we should monitor the levels of voriconazole. So the answer is A. So let's see the proof from our pharmacology book, Goodman and Gilman. So the first question is empty stomach or it should be given with meals. So we can see that because high fat meal reduce voriconazole bioavailability, oral voriconazole should be given either 1 hour before or 1 hour after the meal. That means it must be given empty stomach. Second point, voriconazole is metabolized by CYP2C19. Now, the next question is that therapeutic drug monitoring is frequently used and the target serum concentration should be measured with voriconazole. And the last point is that loading dose of voriconazole should receive loading dose of voriconazole. Okay. So these are the 3 correct options with voriconazole. Which of the following drugs is a suicide inhibitor? Now remember, suicide inhibitor means any drug which inhibits an enzyme irreversibly. Any drug which inhibits an enzyme irreversibly is known as suicide inhibitor, because this enzyme now is permanently dead, it cannot work again. Now the answer for our question is ritonavir. The answer is ritonavir. Now let's see whether ritonavir is a reversible inhibitor or irreversible inhibitor. What our books mention, Goodman and Gilman mentions that ritonavir is a mixed competitive and irreversible inhibitor of CYP3A4A enzyme. Because it's a irreversible inhibitor, it is a suicide inhibitor. It's a suicide inhibitor. Now the next question is, inhalational nitric oxide is given for the treatment of, which we have discussed multiple times, for pulmonary artery hypertension. We discussed which drugs are given for pulmonary artery hypertension. We discussed a mnemonic also, Pepsi, Coca-Cola. We discussed multiple times in rapid revision and LLR session. So P for prostaglandin I2 analogs like epoprostinol, treprostinil. Prost word is coming in all of them. So they are prostaglandin, even analog, which are considered to be the drug of choice. Second drug is the drug that block endothelin receptor. Endothelin antagonist like bosentan. Bosentan, how to remember? ENTAN, endothelin antagonist. Then we have phosphodiesterase 5 inhibitor. The drug name is sildenafil, which comes with the brand name Viagra, also given for the treatment of impotence or erectile dysfunction, tadalafil. Then we have soluble guanylyl cyclase SGC, in short form activator, riociguat. A drug that directly stimulates I2 type of prostaglandin receptor, selexipag. We developed this drug because it's an oral drug. Normal or first prostaglandin I2 are injectable or inhalational drug. They are not oral. Selexipag is an oral drug. Then very commonly we discuss continuous nitric oxide inhalation is given for the treatment of pulmonary artery hypertension. And remember, it's a repetitive question. It was also asked last year in INI-CET, where nitric oxide inhalation is given. And lastly, we give calcium channel blockers like nifedipine, amlodipine. So these are the drugs which are given for the treatment of pulmonary artery hypertension. Okay. Now next question is, which was asked is, which of the following is the best drug for the treatment of infective endocarditis due to enterococcal fecalis? Now remember here, fecalis word is written. So enterococcal fecalis, let me tell you the treatment. Enterococcal fecalis, instead of fecalis, I will write enterococcal infection if it is causing endocarditis. Now there are two species of enterococci, that is Enterococcum faecium and Enterococcal fecalis. Now in fecalis, A word is coming, remember, okay? Now for endocarditis, enterococcal fecalis, we give penicillin G or ampicillin with aminoglycoside like gentamicin. Now in cases of penicillin G or ampicillin allergy, or in resistant cases of penicillin G or ampicillin, we replace penicillin and ampicillin with vancomycin, and we can write vancomycin with gentamicin is the most effective drug for the treatment of enterococcal fecalis endocarditis. But remember, ampicillin, vancomycin, they are not effective in faecium. If it is faecium, we directly start with daptomycin with gentamicin. Okay, so the best answer out here will be vancomycin. So penicillin will not be given because the patient is allergic to beta-lactam. Allergic to beta-lactam. Beta-lactams, they contain penicillin, cephalosporins, etc. Again, ceftriaxone is also a cephalosporin. In beta-lactam allergy, we don't give. What about aztreonam? Aztreonam is a beta-lactam which can be given in allergic disease of penicillin, but aztreonam is not effective in gram-positive bacteria. And enterococcal is a gram-positive bacteria. Aztreonam is only given for gram-negative infection like typhoid, pseudomonas, etc. Hence, the best drug for gram-positive always is vancomycin. Now, this is what literature says. We can see that in combination with aminoglycoside, this vancomycin, it can be given for the use of enterococcal endocarditis in patients with serious penicillin allergy or penicillin resistant cases. So this is what we have learned, beta. So this is what our Goodman and Gilman pharmacology book mentions. Now, which drug acts by PCSK9 inhibitor? Beta, we discussed PCSK9 inhibitor decreases blood lipid level, LDL level or cholesterol level. It lowers cholesterol. And I have told you how to identify a PCSK9 inhibitor. Find the word LOC. LOC means lowering of cholesterol. Now, can you see the 4 options and identify which drug is having LOC word in it? The answer is evolocumab. So, PCSK9 inhibitor, the drugs are evolocumab, alirocumab. They have been asked repetitively many times from past 5 years. Other drugs, ezetimibe, it is an inhibitor of a protein known as NPC1L1 inhibitor, some Niemann-Pick-like transporter inhibitor, which reduces cholesterol absorption from GIT. Bempedoic acid, it inhibits ATP citrate lyase. The whole concept, how it reduces blood cholesterol level, we have discussed in lectures. And lomitapide, MTP word is coming, it inhibits a protein known as MTP. MTP is microsomal triglyceride transfer protein, we have discussed. So the answer is evolocumab, very repetitive question. Now the next question is, a patient with cough, tenacious whitish sputum, which is the best treatment? Now the patient is having sputum. That means the patient is having productive cough. So in productive cough, what is the treatment? We have to remove this mucus or sputum out of the body so that infection also comes along with sputum. Hence, in the treatment of productive cough, we give expectorants. Expectorants, as the names will tell you, they will expel the mucus out. And we have discussed 3 main drugs, that is BAN, ban. B for bromhexine, bro word is coming. Ambroxol, again bro word is coming. And N-acetylcysteine, which is also an antidote of paracetamol, also used in cough. But remember, there is another class of drugs for cough known as antitussive. Antitussives, they will act on brain and they suppress cough. Remember, if there is no cough, sputum will not come outside and the infection will aggravate. That is why antitussive drugs are contraindicated in productive cough. They are only given in the treatment of dry cough when there is no sputum. And we have discussed 3 drugs in antitussive, DON. D for dextromethorphan, opioids like codeine syrup, and noscapine. So these drugs should be avoided in productive cough. So can you tell me what will be the best answer out here? We should only give bromhexine in our patient. Only and only expectorant must be given because the patient is having productive cough. Now the next question is, which of the following drugs decrease the levels of serum parathyroid hormone? So this is a question which can be overlapped with physiology. Remember, the answer is calcitriol. Calcitriol is active form of vitamin D, which is known as vitamin D3. Vitamin D3 inhibits or suppress parathyroid hormone secretion. That is why vitamin D is also given in the treatment of hyperparathyroidism. But if somebody will ask you a question in opposite way, that what is the effect of parathyroid hormone on vitamin D production in kidney? Parathyroid hormone increase or stimulate the production of vitamin D from kidney. While vitamin D, it decrease the production of parathyroid hormone. So it's a negative feedback. So this is a picture which has been taken from Goodman and Gilman. So parathyroids, when released, they increase the production of, green means increase the production of calcitriol. But when calcitriol or vitamin D is produced, it decreases the production of parathyroid hormone. So this is all about the recall of INI-CET May 2024 examination, and best wishes and thank you very much.